Yeah. It's basically the ERPM thing. The sessions is basically for us to sort of prepare strictly for the exam. So as you all know, the ERPM exam, you might have gone through the MCQs and DOSKIs. It's very clinically oriented, and you'll be asked on a lot of clinical questions rather than the questions which are being asked in your first and second years. So basically anatomy, physiology, or pathology, pharmacology. More than that, what you've been asked in your final exams, maybe in your curriculum as well. And when you come to Sri Lanka and when you come to when you sit for ERPM exams, it's basically a clinical based sort of thing where they will ask you clinical questions for which you need to answer. But for those, obviously you would need your first year to fifth years and every subject matters. Uh, and also one thing we've seen is like, you all are MBBS graduates or learning MBBS over 5 to 6 years of duration, depending on where you learn. So you'll be learning all the basic, or like you'll be learning everything, like all the subjects. It's just what we see as medical students. I mean, we also did this journey and we're just done with our MBBS. So what we learned from this was at the end, we have a lot of information and you have a lot of inputs coming from primarily your undergraduate program. And also there are seniors notes and various other things, where could be, and any like supplementary things done by your own batch mates, and a lot of other inputs, and a lot of information is at your hand right now. But our main goal in doing these sessions is to basically try to give you all like a synthesized version and a short and simplified version of that, so that you can directly apply it for your exam, which is the MCQ and the OSCEs. So I hope, I mean, I think you all got a slight glimpse of what we're trying to achieve, but when we do it, when during the course of this whole program, you will get a hang of what we're trying to say. Okay. So without further ado, we'll dwell into the subject of dengue fever. So when we start to talk about dengue fever, uh, yeah. So to give you an introduction of what dengue is, I mean, all Sri Lankans, how dengue is prevalent in Sri Lanka. I'm not sure if it's that prevalent in other parts of the world, at least in parts where y'all are learning. So as from a ERPM student's point of view, or a person who's getting ready for the ERPM exam, uh, again, dengue is something which is relentlessly questioned during in your MCQs, and can also be a question in your vivas as well. The patient who's coming with leaking, how do you manage? Could be an acute viva, for all we know. So we'll be so the point of this session, this particular dengue session, this session is to basically I'll be covering like MCQ sort of theory points and like other sort of basic information, and then my main goal is to walk you through a process of how you will act as a doctor or as a house officer when you suspect a patient with dengue is there, and how you carry it from there. Because all your SBS is going to be those kind of things. What is the next sort of management? What's the best management? Those are the questions you will be always asked in your SBS. So you should be able to tackle them. And so I'm going to help you by taking you all through a case scenario. Okay. So, and also if at any point you all have a question, you can ask me, and you can reach me through, you can unmute yourself, or you can leave a text, or you can just PM me. Anyways, I'm open for any questions and any clarifications you want. I'll do that. It's open for that. All right. So without further ado, I'll get into the theory component. So yeah, dengue fever as so I'll just cover some bits of theory components. Okay, so basically it's like a viral fever. Okay, it's a virus. Dengue is a virus, so it causes like a viral fever. All right. So if you pay attention to this first uh, image. So as you can see, mainly it's 90% asymptomatic, okay? And then the symptomatic ones are the ones you get this. This is the viral syndrome. This is undifferentiated fever. That's the viral fever which it's very prevalent, okay? And then you have dengue fever, and then you have dengue hemorrhagic, and then there's something called expanded dengue syndrome, okay? These are just MCQ points. Just remember that dengue comes under a viral fever, okay? And then with bleeding without bleeding, we'll be going to that later. The other thing I want you all to have a really important, like good idea about is this whole this is the sort of the summary, actually speaking. This is like the summary of dengue. I want y'all to sort of see. So uh, you see this period, 3 to 6 periods. So 3 to 6 days, that's the time period where a person can lead into dengue hemorrhagic fever. So what do you mean by dengue hemorrhagic fever? Again, I'll be coming to that. Just remember it. So I want y'all to see these things. So here, uh, uh, one second. All right. Sorry for the delay. So yeah, so see, at this point, you see that during this around the third to fifth day, that's when uh, there's a temperature drop. So okay, just remember this there's a temperature drop here. Okay. So just remember this red part is like a critical stage, and then there's a temperature drop at this point. Just remember that temperature drop is there, and then the hematocrit and the platelet levels. Okay, so here the platelet levels start to increase, and here you see this is the platelets. Sorry, this hematocrit. This is the hematocrit. That is the PCV. I hope you all know what PCV. PCV means the volume of RBCs divided by the plasma volume. Okay, so PCV means um, the RBCs volume divided by the plasma volume. Okay, this equation is going to be really important, so just keep in mind of that as well. So yeah, so here the platelets, there's a huge decrease here as you enter this place. Just remember that. So there's temperature drop, and there's a platelet drop as well, and there's a hematocrit increase as well. All right, and then there's this whole organ impairment and the shock and bleeding. Just remember that. Okay, that's enough for that part. Okay, so then going forward. The incubation period is 3 to 14 days, meaning, so what do you mean by incubation date? Incubation period means, so when the virus comes into your body, uh, you know, uh, you get an infection after, that means you're symptomatic. So up until that point, the virus has to undergo viremia and then there's multiplication and all. And when it starts to attack your body and when you start to have symptoms only, you call it, you have that infection. So it's day one of the infection. But the incubation period, so the virus might have been there for a long time. That's like the basic idea of what incubation period means. And that differs from organism to organism, from disease to disease. So in this case, dengue, it's around 3 to 14 days. All right. Okay. And another important is febrile phase is common to both dengue hemorrhagic fever and dengue fever. But critical phase only seen in dengue hemorrhagic fever. Okay. So I will take you again back to this. So yeah, so this is the febrile phase. That is the febrile phase. All right. So this is the critical phase. We'll define what critical phase is later, but this is the critical phase. Now, um, here I mentioned there's dengue fever and dengue hemorrhagic fever. dengue fever, dengue hemorrhagic fever. So these two cannot be differentiated in this period because you don't know at day three if there's going to be leaking or if there's going to be entering into the critical stage. So you can only tell that a patient is in dengue hemorrhagic fever after around 6 days. You can't never say like from the third day that this patient is in dengue hemorrhagic fever. When there's a sort of objective measurement of critical stage, like we'll be going to that, only that then only you can tell that this patient is dengue fever. So again, an MCQ point which is always asked. Okay, so they won't be like febrile phase is only seen in dengue fever and not in dengue hemorrhagic fever. That is wrong. Right? Okay. Uh, Okay, and then this hemorrhagic manifestations. So hemorrhagic manifestations means like bleeding. Okay, it's bleeding, and they are mucocutaneous in nature. So again, to give you a side view, so mucocutaneous bleedings and deep bleedings. I hope you all know what the difference between the two are. So mucocutaneous means bleeding from your gums and from your extremities or sorry your GI system because they are mucus in nature. It's like mucocutaneous. And in compared to that, you have something called deep bleedings. Bleeding into joints, muscles. That is when you have clotting factors, clotting factor deficiencies or problems with clotting factors. But here, as I mentioned, these platelets, it's platelets here. The mainly uh, the bleeding problem comes from these platelets going down. So therefore, it's always going to be mucocutaneous. So again, an MCQ point where we last deep bleeds are common in dengue. That is false. Okay, it's going to be mucocutaneous bleeds. Deep bleeds come in features like hemophilia, where you have factor 9, 8 deficiencies and all. All right. Another MCQ point is asked is the NS1 positivity is highest in the third day of fever. Okay. Uh, so meaning there's no point of you doing the NS1 after around 5 days. So and there's no point of doing NS1 on the first day of fever as well. So what they say is on the third day of fever that's when it's best. All right. Okay. And then okay. And then there's one last thing. This test is more likely to be positive in primary than a secondary infection. The reason being, in a primary infection, like uh, uh, if you take a secondary infection, meaning that if the patient is already been sort of yeah, if a patient is already what you call had already been uh, 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 affected by dengue and now coming back because there are four types of serovas. There are four types of serotypes of dengue. There is some cross interactions between these antigens. So therefore, the more infected you get, like suppose there's a patient who's coming after third infection of dengue or suspecting into an NS1. There will be a lot of cross reactions between the already present antigen from the before infections. So the NS1 won't be that positive. When compared with the patient who is suspected to have dengue for the first time, okay, another key part, okay, and then there are two boxes I want you all to have an idea on this warning signs of dengue and um, categories of patients needing early admissions. Okay, again, I just put it then and there so that I just want you to remember them. Try to remember uh, a certain because again there will be question in the MCQs true false. All right. Okay, so now we've gotten over the like basic theory component, which is like sort of boring as well. So now we'll get into the proper clinical scenario. Okay. All right. So now imagine you are the house officer. So this Mr. X, a 51-year-old patient presenting with fever for 2 days, associated with arthralgia mild. Arthralgia comes to see you. The weight is 50 kilograms. All right. So then, Here I've not mentioned, but in the Sri Lankan context, when you talk about patient coming with fever and arthralgia myalgia, first thing you always have to suspect is dengue. Any viral fever, but yeah, any a person who's coming with arthralgia myalgia with fever, like this is a typical thing, always suspecting. uh, just in the Sri Lankan context, it said that if you like, you could even be penalized if you don't attend to a patient with dengue. It doesn't mean like if you attend late to that sort of patient, you could even be penalized. So always, for your sake, your safety as well as the patient's safety, it's always you should suspect a patient coming fever, regardless of patient not even having arthritis. Always dengue is one of the first differences you should think about. Okay. And then something which is very closely associated with dengue is leptospirosis. Leptospirosis is the other thing which you need to think when you get a patient like this. Okay. Now, and then you go ahead and take a history, and then you have gotten the NS as positive, an HB of 12, WBC of 3.7, and platelet of 250,000. So as you can see, the WBC has taken a small hit down. No? So I think that is one of the parameters that you can use to sort of differentiate from leptospirosis. Because in leptospirosis is caused by a bacterial agent and which causes a neutrophil leukocytosis. Okay, so in this case, it has a neutropenia. There's a lymphopenia, and then the nephron is positive. So now we can ascertain that this is the patient diagnosed with dengue fever. Okay. Now what are you going to do? So at this point, these are the things. Now, this case scenario can be given as an MCQ. You can be given this case scenario. You will be like, what will you do the next step? Okay. So at this point, these are the things you should tell in the Viva. So the patient does not need admission, can be managed at home. This should be bed rest. And then the paracetamol should be 60 milligrams per kilograms for 24 hours, meaning it's 50 milligram per kilogram per 6 hourly. So I'll get it, no? 15 milligram per kilogram per 6 hourly, and you multiply by 4, then you get that 60 milligram per kilogram for 24 hours. All right. Do not give any sense. Okay, because uh, it is used. It is usually practiced in Sri Lanka to give ibuprofen, to give brufen. But some of you might even know brufen, ibuprofen. Never give NSAIDs because for fever in Sri Lanka, right? At least not at the start. After you excluded everything, then yeah, there might be a place like places like Kawasaki syndrome where you have to give high dose of NSAIDs and all, but always never give it at the start. Okay, and then so bed rest, paracetamol, usually each and every one of us do, and then you need to start a input output monitoring. All right. So input output monitoring, you have to start the patient on a maintenance. So what do you mean by maintenance? So maintenance means for every person is going to be 40 ml per hour for the first uh, 10 kilograms, and then 20 ml per hour for the second 10 kilograms. That means 10 to 20 kilograms, and then 10 ml per hour for the third. So you do the calculation. This patient was 50 kilograms. So then you get 40 plus 20, 60 plus 30 is 90. All right. Okay. So uh, just because you have a paracetamol, just because you have a main input, you just because according to calculations and all, you might be thinking, okay, patient's okay, well hydrated and all. But we should always see for the output as well, because the input we are taking might be going somewhere else. There could be bleeding even. There could be leaking at start. We don't know. So you should always see for the urine output. The urine output is very important because that is the best measure. That is the best measure for uh, organ perfusion. This principle goes across any field of medicine. It goes across surgery, pediatrics, and anything. So always remember, urine output is one of the best, or is the best measure for organ perfusion. And there are other components as well, like GCS and all. But yeah, so and there's also like that if the patient has a good urine output, meaning not for just for dengue and all, but for any person with a fever, the urine output, like urine means like your excreted fluids are going out of your body. So that is one of the best ways, nature's best way of getting rid of the fever. So anyone, so it doesn't have to be dengue. For any patient who is having a fever, being very well hydrated is one of the best measures to get rid of the fever, apart from things like paracetamol and all. So I want to stress on that point a lot as well. Okay, so then don't drink red color juices for obvious reasons, because if there's a bleed, we might need to mask what we are looking at. So that's going to be a problem. And then another tricky point is repeat FBC once daily. Okay, so now we are at platelet of 250,000. Repeat FBC once daily. All right, and then if the platelet drops below 200,000, you're supposed to do the FBC twice daily. Just remember that, okay? Because you can be given 190,000 patient just fever. What do you do? Then you should do the FBC twice daily. That's all you do. That's the SBR answer for the next step. Okay. And then you always tell, come see if you have warning signs. That's when I go back to this. So this what do you mean by warning signs? So warning signs means, no, like the biggest problem in dengue is if the patient goes in the critical phase. And that is when there's plasma leakage. Basically, critical phase means like due to the pathophysiology of dengue, which is like complex and still not understood properly, there's capillary permeability increase and hence causes plasma leakage. Okay, so plasma leakage, when that happens, what happens? The intravascular volume reduces, leading to reduced organ perfusion and hence causing end organ failure. That is how. That is the sort of the prognosis of dengue hemorrhagic fever if it's not managed properly. So the whole idea is you call that, there's another term for it called third space losses. So basically the plasma leaking out, that is called third space losses. So what we do in dengue management is uh, try to maintain that intravascular volume, but there's a catch. So I'll get to that later. But mainly we need to sort of make sure that the organs are well perfused, and even there's plasma leakage, we need to make sure there's enough and enough volume inside the blood vessels so that the organs can be function properly. So now what are these warning signs of dengue? So basically, if a patient comes with these, okay, a patient coming with now let's just take this patient. Um, we will be talking about it in the next part. So okay, so now yeah, I'll come to that, but just see this persisting vomiting, mucosal bleeding, no urine output, severe abdominal pain, all signs of possibly that the patient has now entered the critical stage and all. Okay, so this is just for MCQ purposes. You might have to remember this. All right. Okay, so now and then, and also I told come see me if the platelet is less than 150,000 as well. Why? Why would I say that? Because now if that is also a criteria for admission. Okay. So now, uh, so I just recap. Uh, uh, about 200,000, you can just do FPC once, and below 200,000, and if it's between 150,000 to 200,000, you should do the FPC twice. And if it's below 150,000, or if you have warning signs, you have to come see the doctor. Okay, that's all. And then the other things are bed rest and the, what we discussed. Okay, now on day four, again, very important clue. Day four, patient comes to you with a platelet of 120,000 and there's no abdominal pain. What will you do? Okay, now basically this criteria has come into place. No? I told come back 150,000. So, but no plate, no warning signs. So, okay. So, what do you do? So then, what you do is now at this point, uh, you always have to suspect. Okay, is this patient leaking? Is this patient leaking? That's the only question. That's the main question you're gonna ask, and you would do anything at your hand to exclude that. Okay, so that's why you do the vital examination and do it on the focus to make sure there's no. What do you mean? Focus means point of care ultrasound scan. Okay, that is meant by focus is um, point of care ultrasound scan. Okay. So you do that. And the vital examination is why? What do you mean by vital examination? Blood pressure, pulse rate, and you know why stuff like those. So then, respiratory rate, less VO2s. So, what would you usually expect if the patient is leaking? So it's like leaking, no? So there is plasma is leaked, so that the intravascular volume is depleted. So you will be tachycardic, and what sort of pulse pressure will you have? You will have a narrow pulse pressure. A narrow pulse pressure. Why? Meaning, what do you mean by pulse pressure? Means the difference between the systolic and the diastolic blood pressures. So your systolic blood pressure is mainly dependent on the blood volume, while and the stroke volume. Sorry, dependent on the stroke volume. Going back to cardiac physiology, stroke volume, and then uh, and stroke volume is mainly dependent on the preload, and which is dependent on the intravascular volumes and all. So that is that. And then you have the diastolic volume, the diastolic pressure. The diastolic pressure is mainly dependent on peripheral vessel constriction. So your blood vessels they constrict. Then that is what gives rise to the diastolic blood pressure. So what happens is dengue is there's leaking. This is like basically like hemorrhage. There's leaking. Therefore, your cardiac output, the stroke volume will be reduced. Therefore, the systolic blood pressure will come down. While to compensate that, to maintain perfusion to the organs, the uh, vessels inside the blood vessels will constrict, causes try to compensate that, and hence the diastolic blood pressure will go up. So systolic minus diastolic, that difference will be reduced. That's why the narrow pulse pressure is what you see in uh, if you suspect the patient is having hemorrhagic fever, you have to suspect that if the patient has like a narrow pulse pressure. If the usual pressure is 100 by 20 is 40. So what the guideline says is if it's less than 25, then it's again a marker of that. And we'll be coming to that as well. Okay. And then, so now you've done the vital examination and all. Yeah, so, okay, you know that no leaking yet, nothing. It's just the platelets are reduced below 150,000. That's okay. So the difference between is now the difference only is the fact that now the patient has to be inward managed. That's the only difference here. Just the platelet coming down. Because why do we do that? Is because now the patient has a higher tendency in going into critical stage. We still don't know, which has still not happened, but we don't know. But there's a higher tendency. That's why we're going to admit. I mean, ideally, you would want to admit all the patients dengue, but that's not possible in a low resource healthcare sector. So that's why we sort of have these sort of guidelines and cutoffs to try and minimize as much, but now below 150,000 is not a chance you would want to take. That's why most guidelines recommend you to admit, even though there's no leaking and all. Okay. And then as I mentioned, continue with the same management. Okay, inward, same management. And the only thing is, had be under cannula inserted. Why? Cannula insertion is very important at this stage because suppose if the patient goes into leaking quickly, they will the you have something called peripheral shutdown where your veins will not be able to be accessed, and hence then you have other problems as well. So therefore, you would want to, when the veins are there, you would want to have cannula as well. Okay, and then you have to start something called the febrile charge. So what do you mean by febrile phase monitoring? It's basically 4 hourly. Okay, just remember these. Okay, these are very important. Febrile phase monitoring happens every 4 hourly vital measurement. Basically, all the vitals, meaning the blood pressure, pulse rate, SpO2, respiratory rate, and the urine out mainly. And some places just GCS also, but mainly those 5 parameters will be monitored 4 hourly. That is what febrile phase monitoring is. Okay, and then twice daily invert FBC invert manage seeing, but we've done that before as well. You know, where below 150,000, below 200,000 we need to two times now. So that's okay. All right. So is anyone clear? Everyone clear on this up until this point? Because now we'll be going to a bit into the critical stages and all. So if anyone has any problems, now can let me know. I can clarify. Go back and clarify up until now. All right. So seems all okay. Yeah. All right. Now we are like entering into like a sort of a okay. Now it's day 5. Patient has come, and now it's day 5 of the illness. And now in your daily ward rounds in the morning, you see the patient now complaining of abdominal pain. And the urine output is around zero point 0.3 ml. This is the ml kg per hour or 6,000. 6,000. The platelets are 96,000. What do you do? Now, again, your suspicion is now going to be much higher towards, okay, is this patient leaking? Because this patient is, uh, it basically, yeah, if there's any sort of leak of plasma to the outside. Why? So, okay, now we'll talk about how abdominal pain comes in, how abdominal pain comes in dengue hemorrhagic fever. So what happens is when you have plasma leakage and all, you have the capsule around the liver. It is very tense, and this sort of inflames, and there's plasma leakage and all. Uh, it could like sort of there's a lot of pain in it, and you usually get a right upper quadrant pain. That is one reason why you get dengue when you get abdominal pain in dengue hemorrhagic fever. And also other reasons could be the fact that the organs are less perfused. So therefore the organs itself can undergo inflammation, give rise to pain as well. And then another reason why you can get abdominal pain in dengue hemorrhagic fever is you get collection of plasma in potential spaces. We getting into what those spaces are. So these are like the pericholecystic, hepatorenal pouch, pouch of Douglas, and the pleural effusions. So they are basically plasma leaking to various places in the body. Some the pleural effusion is again a potential space. Pleural cavity is a potential space. What do we mean by potential space? A potential space means it is not a space which is usually present, but if there's something going in there, it could potentially be into a space. That is what we mean by potential space in medicine. So these are reasons why you get abdominal pain in a patient with dengue hemorrhagic fever. So when the patient says, okay, now abdominal pain is there, and then urine output is also 0.3 ml per kg per hour. So what is the usual thing? It's 0.5 ml per kg per hour. So now we can see now, okay, this patient's not well perfused, and there's some abdominal pain in the context of diagnosed patient with dengue. And the platelets are also 96,000. Okay. So on day 5, on day 4, it was 120,000. Now it has come to 96,000. And day 5 was, that's also very important. Day 5 of the illness. Okay. So now, uh, the questions I should be asking myself is this patient in critical stage? And is he in shock or not? Okay. So now we will, I've like spoken a lot on how you suspect if the patient has gone into critical phase. So it can always in our MCQs, not in our MCQs, but in our vivas and all, when you're being asked a clinical question, uh, it's always sort of safe if you go by this uh, uh, like what we call classification of your, always try to classify your answer under history, examination, and investigation, because any clinical scenario encounter, you'll be using all these aspects to manage a patient. Only after history, examination, investigation are you going to manage the patient. Therefore, always try to incorporate whatever answer you give anywhere and in place under these three categories. So it's more very methodical. Okay. So what are the causes or what are the indicators of a patient going into a critical stage? So here, usual onset is on day 4 to day 5 of the illness. Okay. So a patient now this patient is in day 5. So uh, comes well within the time when where we suspect the patient goes to critical stage. And then there's something called a clinical deterioration despite temperature drop. Very important. Okay, so I would want to take you all back to the first page. See, this is why I told you all to have an eye on this. This temperature drop. So in this patient, uh, their temperature drops, but they are much ill than the days before. So usually when you have a fever and you come out of the fever, you're good, you eat, you are active and all. But in these places, the temperature has a huge drop. The almost nothing, but patient is much bad than did the day before. Again, another indicator of saying that might be going into this. And then appearance of the warning signs. Now, in this case, the patient has got abdominal pain. So, and that's why I keep coming to this figure, because uh, uh, they could give uh, not because abdominal pain, which we are very common with, that they could tell that the patient is coming with persisting vomiting, a dengue patient coming with persisting vomiting for one reason. So you might think it's something else, but again, that's all a feature of clinical what you call it, critical stage. Okay, it's not just abdominal pain, even though that's a commonest. That's why it's important that you remember that box. Okay, so now history is okay. So those are basically the things to say. Okay, this dengue patient, these are getting maybe going towards critical stage. And then on the examination, we have CRFT and the peripheral color. So remember, CRFT is capillary refilling time. So usually it's less than 2 seconds. But what happens when a patient is leaking or when intravascular volume depletion has occurred? The CRFT is going to increase, yeah, because the perfusion is reduced. And then blood pressure. And blood pressure, the most important thing is something called the postural drop. That is the most indicative, in the sense what you do is you get the patient seated, is lying down, and then you measure the blood pressure, and then you make the patient sit up. And after 3 minutes, you measure the pressure. So if the pressure is, if the systolic is less than 20, and if the diastolic is less than 10, uh, the difference of that means that the patient has a postural drop, and that is one of the best indicators of the intravascular volume condition. All right. So not just measuring the blood pressure, but you make sure that the patient is like lying, and then you get the patient up, and after 1 to 3 minutes, you measure the blood pressure again. The systolic blood pressure is less than 20, and the diastolic blood pressure is less than 10. That means that there is a postural drop. Okay, and then you have the abdominal tenderness, which I explained explicitly, and then auscultation revealing pulmonary edema. What do you mean by auscultation revealing? Sorry, this should be changed into pleural effusion. Sorry, change that in pleural effusion. So, auscultation revealing pleural effusion. So, I will get down to what pleural effusion, how it happens. So, just a summary of how what you will expect in a pleural effusion is you will get uh, reduced. Suppose you have right-sided pleural effusion, which is commonly that happens. That is what commonly happens in dengue. You have right-sided. The air entry will be low. It will be stony dull for percussion, and then on auscultation you will have reduced bed sounds. It will be stony dull on percussion, reduced bed sounds, and reduced vocal resonance. Okay, those are the main three things you see in pleural effusions. Okay, all right. So now you have that, and now do the investigations. So investigations, the main or the earliest indicator of entering into critical phase is the platelet. That is the main thing. So if the platelet is less than 100,000, you can very much say, okay, now probably has entered critical phase. That is one of the closest indicators. Okay. So, and also there's something called 20% increase of the PCV from the baseline. 20% increase of PCV from the baseline. So it's very important you learn what that means, because that's also a thing which a lot of people sort of uh, confuse. So what do you mean by 20% increase of the PCV from the baseline? So all this time, you've been doing FBCs twice daily. So all these FBCs, you'll be getting a PCV value, and from that you can get a baseline idea. Or just say it's X. So an increase in PCV, 20% increase of PCV from the baseline. So then you have 100 into 120. So if you get this value for your PCV, that means uh, you sort of uh, again indicated that there's leaking has occurred. Because I mentioned here, that's why I mentioned here, PCV means RBC volume divided with the plasma volume. Okay, so if the RBC volume, so RBC volume is not going to change because there's no hemorrhage, it's just leak of plasma. Therefore, this will come down and this will go up. And that happens is so you get the PCV to go up. Okay, so when that happens more than 20% from the baseline, uh, that's when you again call uh, maybe suspect. Again, you suspect patient is going into critical stage, and then but all this time, all what we've talked, I'll just leave this point of care ultrasound scan there. And then there's something called, if not conclusive, you can do serum albumin, serum cholesterol levels. Again, MCQ points, this can be asked. Okay, so just remember that you can do serum albumin, serum cholesterol. You won't have to know the values per se, but know that you can do albumin, cholesterol levels. Okay, so whatever said and done, now we all these tools, history, examination, investigation, everything we've used is to sort of suspect that this patient has gone into critical phase. But none of this will diagnose dengue hemorrhagic fever. So the diagnosis of dengue hemorrhagic fever is primarily going to be objective evidence of uh, fluid collection. That is the definition. Okay, so it's going to be the objective evidence of fluid collection. So how do you objectively say? So objective means you have like sort of a measure, or you can see something properly, or you use a scale or something. So for that, you do the focus, which is the point of care ultrasound scan. So you should be able to demonstrate that there is fluid collected anywhere in the body. Okay. So now, uh, uh, so now suppose now, I mean you now this patient at this point. Okay, we'll just uh, go through the things and then the scenario will guide us through. Okay, so just remember polycystic fluid collection, meaning around the around the gallbladder you have something called pericholecystic fluid. So if that appears, that means the patient had entered critical stage 2 hours before. These are arbitrary values because they are not properly researched, but this is something which we use in the clinical day-to-day practice for us to estimate when the patient would have coming to critical stage, because that is going to be important for critical stage management. And then you have the hepatorenal pouch. This hepatorenal pouch, yeah, between the liver and the kidney. So if that happens, you see that, that means 6 hours before that has patient has gone into that. Huh? And then you have the pouch of darkness. So pouch of darkness, you see the lower abdominal cavity. Okay, so in the anatomy, you can see that the pouch of darkness, and that is so that means that it has happened 12 hours before. And pleural effusion. Pleural effusion means fluid collection in the pleural space. So if that has happened, you see that in the patient who is with dengue, that means it has the patient has gone into critical stage 24 hours before the time you are examining the patient. Okay. Okay. So now in this patient has low temperature despite clinically deteriorating. Okay, so that history point is okay. And the focus reveals hepatorenal pouch, fluid in the hepatorenal pouch. So hepatorenal pouch means so 6 hours. So meaning, so day 5 of the illness, when you are seeing this patient, now you have objectively shown that you have confirmed that the patient is going to hemorrhagic fever. Why? Because there is fluid in the hepatorenal pouch. All right. So then, uh, now we have confirmed, we have asked this first question, is this patient in critical stage? Yes, patient is in critical stage now. The second question I should ask myself is he in shock or not? Okay. So what do you mean by shock? Confirms. Okay, so because here, yeah, before that, so here, focus reveals, so confirms patient in critical stage of DHF and has approximately entered 6 hours before. So I hope all of you all got an idea of what I'm talking about at this point. All right. Okay. So then the next thing is this patient in shock? That's the second question I should be asking, because shock means shocks. What do you mean by shock? Shock is not something which is uh, limited to dengue. It's limited to all of medicine, all of overall medicine. Shock means there is reduced perfusion to organs. That is the basic definition of what shock is. Okay. It could be distributive shock, it could be cardiogenic shock, it could be neurogenic shock, it could be hemorrhagic shock. So whatever it is, if there's reduced perfusion, if the organs are reduced, upper is reduced, low, that means that patient is shock. So what are the clinical features of shock? Okay. So here you see abdominal pain, altered consciousness. So yep, CRFT. This is more than 2 seconds. Tachycardia here, and you see narrowing of pulse rate of less than 20 or hypotension. So as I mentioned, the SPP minus TBP. So I told you this comes up, this goes up. So if the difference comes less than 20, that is an indicator of shock. Okay. All right. So again, a box which you don't have to by heart. It's mainly, or if you just compare it with the abdominal the warning signs, it's basically the same thing. It's just that did not have the CRFT and the narrow pulse pressure thing. So other than that, other things are almost same. Okay. Now we are in scenario 1. Patient is in critical stage, approximately reaching their 6 hours back. No features of shock. How will you manage? Okay, now we diagnose, no? We diagnose patients in shock, in clinical, in critical stage. And as why 6 hours before back? Because we mentioned that there's fluid in the hepatorenal pouch. Now, no features of shock though. You examine the patient, there's no shock, the blood pressure is okay, check. So how do you manage? So now this is what I'm trying to elicit, or what I'm trying to teach all here is the critical stage management. Critical stage management. Okay. So here, the patient ideally has to be put into the HDU from the ward, and then you have to start. Now, you up until this point, the patient will have having a febrile phase monitoring chart, which we monitored 4 hours. 4 hours. Now, vitals have been monitored hourly. That is called the critical stage monitoring. Critical stage monitoring, in other words, is monitoring vitals hourly. Febrile stage monitoring means, in other words, monitoring of vitals 4 hours. Okay. Now comes to a very confusion, or like something which is like not taught properly, and like very, there's a lot of confusion around this whole how to calculate this fluid quota business. Okay. So how do you calculate the fluid quota is, you have the fluid deficit and the maintenance for 24 hours It has to be given over 48 hours until the patient comes out of the critical phase. Okay, so now let's take like if you take like a normal patient a person, like this is basically dehydration, no? So when you have dehydration, or like yeah, you can take it like that or for anything that matter, you have something called deficit. The deficit means at this moment what is not there, because you need to replenish that. And then you have something called the maintenance. So maintenance means maintenance. Every hourly there's a particular maintenance which every human needs. That is that. And then there's something called the ongoing losses. That means if a patient vomits, or if the patient has diarrhea or anything, you have to replenish those. So those are the three paramount features of fluid management in a nutshell. Okay, simple as that. Again, anyone have any problem? Because this is very important. This will you will need this in pediatrics, you will need this in surgery, you will need this in everywhere. Okay, so you need to know the basics of fluid management and fluid basis. So this is the main cornerstone. Okay, so deficit, maintenance, and ongoing losses. So now the tricky part here is so fluid deficit. Okay, so fluid deficit in dengue. Always remember, fluid deficit means 5%. Okay, the deficit we calculate is 5%. So 5% means 50 ml per kg. So 5% deficit means 50 ml per kg. All right. Uh, 50 ml per kg. Sorry, guys. Yeah, I think there's a typo here. So, what happens is here, yeah, I want to, I'll just make it here, okay? So always deficit plus maintenance, okay? So in dengue, I said deficit means 5%. It's called a 5% deficit. So this deficit, the percentage means 10 ml per kg, okay? 10 ml per kg. So in anywhere, in pediatrics, you have moderate dehydration, severe dehydration. They will have 10%. So 10% means 10% deficit means 10 into the percentage, 10 into 10. That's 100 ml per kg deficit. Okay, so like that, when you come to dengue always uses a 5% deficit. We always assume that the patient is in shock. Okay, when the patient is in critical stage, that means there's some fluid has gone out. We will think, okay, now this patient is dehydrated to some extent. Therefore, this patient is having a 5% deficit. So 5% deficit means it's a 50 ml per kg. Right? So it's 50 ml per kg into what is the patient's weight? It's 50. Okay. So then that is a deficit. That is a deficit amount. This all right. Just concentrate on what I'm writing because I think there's a small typo. I'll make it. Mm, oh no, I think no, I got it wrong. So here, yeah. So this is this part. Yeah, this is the deficit. Yeah, this is the deficit. This is the deficit that I mentioned, 50 ml per kg into 50. And then what is this? This is that's the maintenance. So for maintenance again, I told you there are two ways you can calculate the maintenance. You can calculate the maintenance for 1 hour. And then there's an equation to see for the maintenance for 1 day, like 24 hours. Maintenance for 24 hours or like 1 day. That is what I said, 4:2:1, where you get for the first for the first 10 kilograms is 4 ml per k for 4 ml per hour, then 2 ml per hour, then 1 ml per hour. But you can also use this equation, which is 100 ml per kg for the first hour, first 10 kilograms. And then you have 50 ml per kg for the next 10 kilograms. And then you have 20 ml per kg for the rest of the kilograms remaining. So here in this equation, so the first 10 is this, and then the next 10 is this 50 ml per kg, and then the remaining there's 13 to 20. So you can see the maintenance the patient needs is 2100 and the deficit is 2500. That's 4600. Now this is the quota. Okay, so now as you've seen, so now the critical phase, when you take a critical phase, it's usually it can range from 24 to 40 hours, 48 hours. There's no place in there, no rule saying that it has to go till 48 hours. So there's no rule saying that it has to end end between end within 24 hours, anything. We don't know. It depends from person to person. But this fluid quota, this equation is same for all. Okay, the deficit is 5% deficit, which is a 50 ml per kg rule. And then the maintenance, this is the thing which a lot of people get confused. So this maintenance, so some people think if the patient goes for critical stage for 2 days, that means the maintenance has to be doubled. That is not the case. Okay, so maintenance for 24 hours is used plus the deficit. So that is our total fluid quota that can be used to manage a patient in the fluid in the what do you call in the critical stage. All right. What happens if you give more is the thing which I told at the start. So the dengue, the problem is there's leaking. Okay, so there's leaking. Therefore, you need to give fluids and you should maintain the organ perfusion. But what happens when the patient comes out of the critical phase is all that fluid which went out will come back in. And if you have given a lot of fluids, the fluid overload will come and it will cause acute heart failure, and that can cause sudden death. That is how a lot of people die from due to iatrogenic causes when the patient is overly managed. Okay, so that is why this fluid quota is very important, that you need to keep it within that range. Okay, so always remember maintenance plus 5% deficit. That is the fluid quota. Okay, that is your tank, or that is the money in the pocket that you can be used to carry on the patient uh, until critical stage is over. Okay, there's no question about it. And if you have any other questions, just let me know. Okay, and then and as I mentioned here, I've told the patient already has been in critical stage phase for 6 hours because the focus revealed that the patient got fluid in hepatorenal pouch 6 hours back. So, but at that point, we've just given the maintenance. So we need to sort of deduct the maintenance for 6 hours. Okay, so here this is the maintenance which we calculated, and divided by 24 is the per hour what we've given into 6. So that means we deduct that part where we have not seen, we did not detect. No? So now this is actually the remaining in the quarter. This is actually what we can give to the patient. Okay, so we need to do that calculation as well. And but however, now even though this is the quota, this doesn't no another reason thing which people do as a mistake is they sort of divide that then by the number of hours remaining in the critical stage. Now this patient is 6 hours gone, so that means if someone thinks and it takes 48 hours, so 48 minus 6 is 36. So the patient will they will divide 4075 by 35 and then give that time. But that is not the case. Okay, the rate you give fluid is based on the urine output. It is not based on anything else. It's just a urine output. Okay, so we always start giving the patient like 1.5 ml per kg per hour. And if the patient can tolerate, fluids, we can give 1 ml per kg per hour by oral, by 0.5 via IV to maintain the veins open. But if the patient can't tolerate, then we can straight away go for 1.5 ml per kg per hour through IV fluids. Okay, and So that is that. So how we are going to change that rate of fluid infusion is directly going to be dependent on the hourly urine output, which should be around 0.75 to 1. Never on the how much fluid quota we have or anything like that. Okay, get that into your mind. Okay, and then now we have come to the critical stage, the other parts. So what the first thing is, we have to mention the HTU, critical stage monitoring chart is hourly monitoring, and then you have to calculate the calculate the fluid quota and then give it accordingly, and then you have to measure the urine output. Okay, and then here do the inward PCV 6 hours. So up until this point, we been doing FVCs every two times a day. No? So, but now from here on, you have to do 6 hour PCV, and not you don't have to do FVCs. You just have to do the PCV because that is what you are going to monitor. And then these are the main goals. So these are the main things we are going to look for. 0.575 to 1 ml per kg per hour, a pulse pressure of more than 30, and a CRFT less than 2 seconds. So this is always going to be our goal. Every time you go and see the patient hourly, you go to see the patient's urine output is this, the pulse pressure is this, and the CRFT is this. So you always try to look for those. You, yeah, I hope it's sort of uh, clear for all of y'all. So again, if y'all have any problems with this, just let me know. Because again, a very point which is confused a lot. Okay. Um, and then we will go to the scenario two. Same patient here, the same patient here who who is here, the same patient. Now here we told that the patient did not have features of shock. Okay. Now here the same patient, suppose the patient had features of shock and the blood pressure is 90 by 80 CRF is less than 2 seconds. So now what does that mean? That means the patient has a narrow pulse pressure, uh, which is less than 20, it's less than 20, but recordable BP. Hence, the patient is in DHF with compensated shock. So this is, so I want you all to focus on this. So this is a patient with shock. Okay, so patient with shock meaning I told you there are features of shock, there are clinical features of shock. So I've taken this. It could be the ZRFT is less more than 2 or the narrow path pressure of less than 20. Okay, so once that occurs, so in this case, you see, compensated shock means its blood pressure is recordable. Uncompensated means the blood pressure is not recordable. Okay, so that's no pulse and no. So in that case, you have to go for a rapid 20 ml per kg free fluid until the pulse is palpable. But I want this is the one which is asked the most, this part. So what happens when you have this sort of a patient is you then give a bolus, a fluid bolus of 10 ml per kg over 1 hour. Very important. You have to remember this 10 ml per kg per hour 1 hour. It's not 20 ml per kg, which is usually given as bolus. This is 10 ml per kg over 1 hour. And then you reassess. And when you reassess, if there's no response, okay, if there's no response, meaning if the pulse pressure is still less than 20 and the patient has features of tachycardia and all, meaning, and the urine output has not increased, that means you have to give another 10 ml per kg over 1 hour. So, okay, so it's 1, 2, okay. Now 2 and then reassess no response. Then you have to go for something called dextran 40. Dextran 40. So dextran 40 is like a volume expander. So you have to give 10 ml per kg of dextran over 1 hour as well. So that, and then if there's no response to that even, then you have to go for this ABCS management, and I will get into what ABCS means. Okay. So this is very well. This is also a lot. Like they always come with. We get in MCQs. We'll be talking about that. Okay. I will be coming this back to this diagram. Okay. And on the other part, it's just the if there's shock, you will have to go with the uh, free flow of 20 ml per kg. That is free flow. That is the normal bolus which we usually give in medical scenarios. And then, and depending on if the patient responds, then they come back to the same algorithm like this. Then they come to the 10 minute per kg over 1 hour algorithm. Okay. All right. So see, this patient was now then given two boluses of 10 ml per kg, zero point 0.9 NaCl. Still the BP is 95 by 50, 80. Europe output is less than zero point 0.5 and CRF is less than 2, more than 2, meaning that it still has not responded after this and this. So now we have to give this. No, this is the according to guideline. This is what you should give. So we'll be coming into dextran 40, 10 ml per kg over 1 now. That is the next step. And we need to, these are the key points you should know about dextran. Okay, so dextran is only recommended during the critical phase. You should never use that before, like in the febrile phase or anything like that. And it should be given over a rate of 10 kg per hour over maximum 1 hour period. Okay, and then again, why this? Because these are like these are blood products which can cause anaphylaxis and other problems. They are not uh, safe, like saline or like crystalloids and stuff. So therefore, you should be very careful and should be given over like a certain duration of time. So you can't just freely give that. Okay, and so you see, you have to do cross matching before you give dextran. So these are all key points which can come as MCQs. That's why I put it here. Okay, you can read it out. And so there is expected PCV drop of 8 to 10 from the pre-infusion value. If the drop is more than 10, you have to suspect concealed bleeding. So that's another concept which will be coming into. Okay, so you can just read whatever it is. This is just all MCQ points. And so, in a clinical sort of point of view, why would you use dextran? One indication to use dextran in dengue management is this whole thing. You are given two bolsters of saline and not working, you can go for dextran. So volume expand. The other thing is, suppose now here, other than that, it could be also be if the estimated fluid quota would exceed. So, for example, we had 4075 and we have duration around 4000 in the next 12 hours. Then it is obvious that the fluid quota is going to exceed. In that case, also the extent can be used. That's another indication for the extent. Not for a patient not in shock, basically. You're almost going to, you can go for saline because then you can going over the quota. Therefore, you can use the extent at that point as well. Okay. Now, still the patient does not respond. So then what do you do? That's when you need to think of the ABCS here, this part. So what do you mean by ABCS? So it's a mnemonic, acidosis, bleeding, calcium, and sugar. So basically, if the patient at this point, now now what has happened to this patient, we have given boluses, fluid boluses, and then given dextran, and now still not responding. We have to exclude ABCS, this is acidosis. Acidosis, how we're going to do is you can do an ABG. And if the pH is less than 7.25, then you have to give the treatment I mentioned, sodium bicarbonate. Just remember that. I don't think you need to know more about that. Just remember the treatment, bicarbonate, if you can, 1 ml per kg. And then bleeding. So bleeding, very important. I'll get to that in a bit. And then calcium. So you have to do calcium levels, and also you have to do the sugar levels as well. And if its calcium is low, that means it's symptomatic hypocalcemia, which you need to give 10% calcium gluconate 10 minutes over 10 minutes. And then for sugar, it's 2 ml per kg bolus of 10% dextrose. So this bleeding, again, another point which people get confused. So PCV drop without clinical improvement and drop of PCV is more than 10 with dextran. So what happens? So there's something called like, now in dengue, what I mentioned was there is like, there's fluid coming out and the PCV sort of increases, that is what should happen, no? The RBC divided by plasma. So this remains stable and this comes down. That is what happens usually. But what happens is, so as a result, the PCV will go up. But what happens if there's like something called bleeding, if there's bleeding also, that then what happens is this RBC will also come down. So the rate at which PCV rises will be low, and uh, uh, sorry, yeah. So in the sense, or the suppose PCB drop. So suppose like the patient had a PCB of 45, okay, and suddenly it's gone to 40, but the patient is still not responding well. It's is sort of having is clinically deteriorating. But usually we told like what why would the 45 become 40? That's when usually that happens when the patient is improving, where the plasma is coming back, and therefore the PCB will come down. Okay, I hope you all understood. So basically, when you are like recovering from dengue, what happens is the plasma which went out will come back. Therefore, this plasma will go up, the volume of plasma. Therefore, the PCB will come down. So this is in a picture of a patient who has good clinically they are okay, they are getting better. But suppose this picture happens in a person who is clinically deteriorating. That means more likely that what is happening is there's the RBC is also coming down. So what happens is when the RBCs are coming down, the PCB will also come down. Okay, so you will get a reduced PCB, but the patient is deteriorating. Again, an indicator that the patient means we have having a concealed bleeding. That's the B. And also this drop of PCB more than 10 after the extract. So what does that mean? So PCB again RBC. So here what happens is the when we give dextran, what we do is you artificially increase the plasma volume. But here, as I mentioned here PCB should be measured before and after administering dextran 40. Expected drop is 8 to 10. You get it now? So 8 to 10 by because when we give PCB, when we give dextran, obviously plasma value is going to go up, the volume. But here, and the drop has to be 8 to 10. But if it is more than 10, that means while this came up, there's some bleeding also happening. Therefore, the RBC concentration is reduced, and therefore the PCB drop will be more than 10. It will be more than 10. So that is also another indicator that there might be concealed bleeding. Okay. So I hope you all like, got a hang of this whole concept of bleeding. And that is not leaking. Okay? Bleeding and leaking are two different concepts. Okay. All right. So then again, MCQs when we ask inotrope steroids can be given. They are not recommended right now in the guidelines. Okay. So then patient was found to have bleeding, and subsequently there was the patient was found to have tonsil bleeding as a PCV drop was 50 after the extent 40. So that means the patient had bleeding, and then we manage it with 5 ml per kg renal cell red cell concentrate over 1 hour. Okay, that's a treatment given, and then from here now it is managed well, and then now basically now the patient has come back to the critical stage, like the stage like be here this point. So now again we can manage the patient. Now the patient was went to critical stage, then went to shock, and then had bleeding, and now everything we've sorted out the bleeding, the patient out of shock, the patient now has been brought back to the critical stage. That is what I mentioned by here. Yeah, at this point, by this point, like this, uh, at this point, that means basically it has come back to the critical phase. And now, uh, so here to make sure the all fluid boluses RCC are deducted from the calculated fluid quota to avoid fluid odor. Always make sure that you calculate all the fluid given. It could be RCC, it could be all other drugs, everything. You have to deduct it, and you have to always have an idea of how much fluid quota is there, because if that is going to exceed, then you can again an indication to go for extract. Okay. Now, so we were at stage phases. So the patient was in febrile stage, on the critical stage, and then now in recovery. So now we are here, somewhere here. We are waiting till the patient gets into the recovery. Now it's now day 8, and patient has a good appetite and temperature fixing. So then, what do you mean that? So possibly enter the into recovery phase. There's again a mnemonic called ABCD. So ABCD is used as a mnemonic to show that the patient has entered recovery stage. So it's appetite, bradycardia, convulsive reaction, diuresis. Appetite means the patient gets, wants to eat and all. Bradycardia. Why do you get a bradycardia? Because now what happens is initially in the critical stage, all the fluid went out. Now it's come back in. Now there's fluid overload sort of a picture. Now what happens is your blood pressures will start to go up, your everything will go up, then therefore you want to reduce the heart rate, no? To reduce the blood pressure, one way of getting that is reduce the heart rate. So that's why bradycardia comes in. And then you have the convulsive rash, that's why you get itching, mainly it happens in the soles. And then the diuresis. Diuresis means now the kidney is getting perfused more than what is needed, because now all the fluid which went out came back in. Now it's diuresis, so you will be passing a lot of urine. Okay. So that is that. And then they say on day 9, the patient is complaining of shortness of breath. So then what to do? So then usually two things which can always you have to think of is, could it be fluid overload? It could be a secondary bacterial infection, because you know why this patient has been in the ward for 8 days, and then very likely that the patient might have gotten an infection, a respiratory infection. That is uh, one thing you should think of. The other thing is, we might have gone over the fluid quota, and then now the patient has difficulty in breathing because patient got acute heart failure. So now, depending on what that is, I don't want to go into detail of how to diagnose each and everything. So this will be covered in other aspects of medicine. So depending on that, you can give furosemide if it's a fluid overload. And if the bacterial infection, you can go for something like piptat, because hospital-acquired infections, pseudomonas, and all the notorious bacterial infections are there. So you can go for a stronger antibiotic. Okay, so that's like a small complication that you can see when the patient is in the recovery phase, not in the critical phase, but in the recovery phase in complications. And these are the discharge criteria. Okay, so when to discharge means all discharge criteria. So no fever for at least 36 to 48 hours. At least 2 days have left after recovery from shock. Good in general conditions. Liver enzymes are improving, and platelet is progressive rising, preferably over 50 to 90. So this is an important thing. Again, can be asked in the MCQs, can be asked in the SBS. Uh, yeah. So these are the discharge criteria for patient with dengue. All right. So yeah. So that is it. So this is basically the management of dengue, and with that, I want to take you through some MCQs. So some were asked before, and then uh, yeah. So let me take you the first question, which is which of the following can be used to suggest dengue fever in the first day of fever? So a low platelet count. Uh, you can't usually go for that because it could happen in any sort of viral fever. So it's non-specific. It's false. And high hematocrit. Again, a patient with having fever can be dehydrated, cause uh, can cause a high hematocrit. So again, you can't suggest that it is dengue fever on the first day. Okay, but NS1 antigen, so that is true. So the best sensitivity is from day 1 to day 3. Day 1 to day 3 is the best time, and then the dengue PCR, DNA PCR. Again, what it does is it uses the dengue viral, the genetic material, and it's rapidly replicated. And then they sort of it's used the use basically uses the virus, dengue virus. So same as an antigen. So that will be also positive. That can be also be used. So dengue IgM antibody levels that cannot be used in the first day. Why? Because antibodies are something which just formed from the body. We have the IgM, and then so if I can go to the bottom of this, I have put an explanation here in the bottom, the last page. Uh, so there's some the detection of NS1 from blood. is a useful method. It's the highest positivity seen in the first 3 days. Uh, but an NS1 is negative does not mean that it will exclude dengue illness. Okay, and yeah, you can read the other part. So the important thing is dengue IgM. They are preferably seen after the fifth day of the illness, so they are not used in the first 5 days of the illness, and they become the choice of diagnosis or choice of investigation if you want to diagnose a patient coming at the 6th day of illness, 6th day of fever with arthritis or anything like that. Okay. Okay, so that's that. So this is going to be false. This is true. Uh, so regarding the dengue infection, so abdominal pain is a warning sign. That's true. We discussed about it. Incubation period is 3 to 7 days. That can be taken as true. It measures 3 to 14 days. That's okay. Once immunity develops for one serotype, it gives immunity for other serotypes as well. That is not true. It's false. And actually, this is something called molecular mimicry of other, in the sense like, actually speaking, uh, our body will have like an exaggerated immune response if the patient gets a second infection. So that means, in clinical terms, a patient getting dengue for the second time will have like a poor prognosis than a patient having for the first time. All because not of the dengue serotype is virulent or anything, but the immune response, the host immune response is a bit exaggerated. So that will go on to cause cytokine storms and all loss of like irregulated host response. So, um, but uh, like getting infected once and then there's no rule or nothing saying that you will not get infected. I mean, if you get infected by the same serotype, then yeah, you're immune, but not for the other serotypes. Okay, and patients become ineffective during the recovery phase. So yeah, that is true. And the main vector in Sri Lanka is Aedes aegypti, not albopictus. Okay. Uh, all right. So those are two MCQs, and then we go to uh, sorry, sorry, this is true and this is false. And now we'll get into three SPAs, important ones. Okay, so a 21-year-old previously healthy male presented day 4 with these vital parameters. Platelet count is 90,000, PCV is 44, CRFT is less than 2 seconds. Okay, so there's ultrasound showed gallbladder edema, no signs of infection. Critical stage management was started and was given 100 ml per hour of normal saline. Okay, so next day the pulse rate has increased, blood pressure has dropped, and platelets have come to 20,000, and the PCV is 44%. CRFT is more than 2 seconds. Ultrasound revealed hepatorenal pouch, pleural effusion, urine output for the last hours 10 ml. What is the most likely cause for this hemodynamic instability of this patient? So, what do you all think? So, actually speaking, uh, uh, yeah. So now in this patient, you all see, even though this is another trick which is used in a lot of MCQs and SPS, they give you like a huge clinical scenario. But the main part I want you all to see here is this patient is basically, you see this patient has all sort of problems. No, the blood pressure, the pulse rate has gone up, the blood pressure has come down. It's narrow pulse pressure. There's ultrasounds. There's hepatorenal pouch fluid, pleural effusion, everything, fluids of fluid leakage and all. But the salient feature here is the PCV has remained same. It is not possible if you are having leaking. Because if you are having leaking, that means you're again coming back to RBC versus plasma. This should come down, so therefore the PCV should go up. But here it has not happened. So that is the only clue that you need to take out of this question. This means there is there's a plasma leakage as well as occult bleeding. There's both things happening together. It's not just occult bleeding. You know why it's not just occult bleeding? Because the patient has proper here ultrasound revealed hepatorenal pouch fluid, pleural effusion, meaning there's plasma leakage, which is the definition of critical stage. Therefore, I hope you all got the answer for that. Okay, so like the explanation for that. Okay, all right. So then go to the next question. A 40-year-old police officer presented with fever, headache, arthralgia, myalgia for 1 week. On examination, there was low pulse volume with a pulse rate of 120. On auscultation, there was reduced breath sounds on bilateral lungs with dullness on percussion. Uh, so now we have your investigation values. So, what is the most appropriate next step in the management? So now, what do you all think? What has happened here? So, what has happened here is, uh, yeah. So, there was reduced breath sounds on bilateral lung bases with dullness on percussion. So, basically, this patient is coming with what is it? So, this PCV is 554%, and it's basically the patient is in uh yeah 100 by 18. So 100 by 80, the patient is in shock. Is in compensated shock. Why is this compensated shock? uh okay, we need to ask what is this auscultation? There's reduced breath sounds and bilateral with dullness on percussion means that is pleural effusion. I mentioned that's the three clinical features or clinical findings you see in pleural effusion now. Pleural effusion now. First is reduced breath sounds. Second is uh, dullness on percussion. Third one is reduced breath sounds, dullness on percussion, and reduced vocal response. So meaning that this patient is coming with pleural effusion. See, very important thing is the dengue is also negative, COVID is also negative. So meaning like you don't need to have that these things positive for you to suspect dengue. Always, if you have the patient coming to you, always suspect dengue, even if the incidence one is negative. And here, especially when there's dullness and all, that means there's a high meaning pleural effusion. You will always think of the worst. Okay? So in this case, and also this there's fever, arthralgia, and everything. So very indicative of dengue. So you will go for. So now this patient is in pleural effusion. What do you mean by pleural effusion? Pleural effusion is again the objective measurement or feature of fluid leak. Fluid leak means the patient is in critical stage. Okay, then the next question we need to ask is the patient is in shock or not. The blood pressure is recordable here. Therefore, the patient is in critical stage with compensated shock. So what we need to do is we need to give the patient 10 ml per kg over 1 hour. So 10 ml per kg over 1 hour. Even though I'm not given the weight, there's only one thing which has critical crystallized. Therefore, the answer is going to be IV normal saline. All right. Okay. If anyone has any problems, just let me know. Okay. All right. Then we come to the last question. So then we have this question. This is the true false question. Okay. So 56 years old patient coming with headache and arthralgia for 5 days. Complaining of shortness of breath. Respiratory system examination reduced. Bilateral air entry. CRF is more than 2 seconds. Social history reviews dengue epidemic in the area. First thing is you are more likely to hear fine creps on respiratory system examination. So this is something another thing which people confuse. So there's you get pleural effusions. In dengue, you can get pleural effusions, and in dengue you can get pulmonary edema. Two different things happening at completely different scenarios. So pleural effusion happens when you basically have it's it's fluid leak, basically fluid leak, plasma leak, which meaning patient comes in shock, not managed, as had stayed at home and coming no with clinically very deteriorated. That is sort of the picture you get in pleural effusion, and that is when you get pleural effusion. In so when you get pulmonary edema is when you overmanage the patient, you give lots of fluids, and then when the patient is coming from critical stage into recovery stage, all those fluid comes in and then causes acute heart failure. And acute heart failure causes the pulmonary edema. So here, what I've tried to elicit is you are more likely to hear fine steps on the RS system examination. It's going to be false because, as you know, pulmonary edema. What are the clinical findings in pulmonary edema? There, you get fine end basal crepitations. That is the fine in inspiratory crepitations. That is the finding you see in pulmonary edema. So what I'm trying to say here is you are not going to get this because the patient is not a patient who's been managed even. More likely the patient is having pleural effusion. The tricky part here is in both pulmonary edema and pleural effusion in sort of any sort of respiratory pathology. If there's respiratory pathology, there's going to be always reduced air entry. It's very obvious. So then you need to identify uh, if the patient is having pleural effusion or they have the pulmonary edema, because they are two completely different things which happens in two different setups in dengue management. But again, people get it confused. That's why I put it here. So you are more likely to hear fine steps on the last minute examination is false. Okay, and then uh, patient enter recovery phase 12 hours back. So we mentioned here that the patient usually the pleural effusion usually is 24 hours. So it's more like it's going to be false. Okay, so it's going to be false. Patient most likely will have a pulse pressure of 25. So um, as you mentioned, so narrow pulse pressure. So uh, if it's less than 20, that is shock. But in this case, we don't know, but it's low. It's on the lower end. It's not 20, but 25. You can take it as true. Okay. And then uh, a 20 ml per kg bolus is treatment of choice. No. Why? Because the patient they have not mentioned anything of a uncompensated shock. So therefore, it's going to be false, and it's usually going to be a 10 ml per kg. Yeah, because why? The respiratory system examination reviews reduced pyrethroid entry, most likely going to be pleural effusion, causing 10 ml per kg bolus going to be an option. And the last one is NS1 is the investigation of choice to confirm diagnosis of dengue fever. Okay, so now this 5 days, no? 5 days, it's not going to be, you are not going to use NS1, that's going to come as negative. So you're going to use IgM. So that is the investigation of choice for dengue fever at this point. Uh, so yeah, so this is sort of an overview and what you as house officers and all you need to know of dengue management. Very important that you get it clarified. And even if you have any doubts, then let me know now. You can even PM me regarding the management because it's very important that you know in and out of dengue. All right. So with that. Without further ado, I would like to end the session. Thank you all for joining today's session of Dengue. And we'll be having a free session tomorrow as well on this CTGs, on CTG interpretation and management. So hope you all join for that as well. So if I don't have any questions and all, uh, can end the meeting. Thanks a lot. Good evening.